Thank you, Prof, and good afternoon once again. I was requested to look at the integration of HPV prevention into HIV care, and I'll highlight some of the perspectives from Zambia as well. We have a high burden of HIV, largely in our women, with the prevalence of 13.2% for those who are 15 to 49 and 13.9 for the above 15. So you can see that disproportionately higher rates of HIV infection in our women compared to the male population. And Zambia has the third highest incidence rate for cervical cancer in the world. And this accounts for over 40% of new cancers. We see approximately 3,000 new cervical cancer cases annually. And we also have a high mortality, with close to 2/3 of those dying from cervical cancer. And it's more prevalent among women who are living with HIV. Dr. Sabrina did highlight the global strategy, the 90-70-90, and I hope by the end of this conference we'll be singing the way we're seeing the 95-95-95 targets. And this is our goal for us to eliminate cervical cancer in our women. We have been having integration models implemented across the continent. We have had family planning and also reproductive health integrated into HIV services. We have had TB integrated into HIV services, STI, hepatitis, maternal, neonatal, and also child health services. And recently, a number of countries have been moving to NCD integration and also advanced HIV disease integration with the routine HIV services. This is from Kenya, looking at where services have been integrated and where they have not been integrated in terms of the cost. When you look at colposcopy, you see that where there is full integration, the cost is reduced to 41, and where there is no integration, it's about 91 for. And also a similar picture is seen where you have full integration even for lip cryotherapy. You see that you are able to care for more people at a reduced cost when you have integrated services as opposed to non-integrated services. And for cervical cancer screening and also the prevention, HPV prevention overall, there are different types of integration that can be. You can have an integrated facility using the internal staff. Then also you can just have a coordination between the co-located clinics and also specialists coming to see, and you can have the complex program of integration and also coordination, which has a mix of the two patterns as well. And these can be in the HIV clinics, infectious disease clinics, the genitourinary clinics as well, the ART, and also in family planning or reproductive health clinics. Really, when you talk of integration, the perceptions are different. You need to look at the benefits for HPV prevention. The benefits to women are large, where you have integrated service delivery, and also the benefits to men as well. Dr. Sabrina did emphasize the fact that as men, we are also not spared from HPV-related malignancies. Then the benefits of the healthcare providers, they are also large, and the funders as well, when you can spend less for taking care of a number of people, and also this brings in the person-centered care as well. But there are a lot of worries which lead to many people shunning away from integration, the workload for the healthcare providers. Some may, because you're going to have a high number of people, so the waiting times will be also long. Then linkages to other departments also have to be strengthened. And sometimes you have, especially from the patients themselves, them being not willing to go to a service where they are going to be told they are HIV positive, but also they may have cervical cancer, or they may test HPV positive as well. And you may have shortages of commodities as well. So those are the various themes that need to be addressed when you're thinking of HPV prevention. So in Zambia, the integration of cervical cancer into HIV services started in 2006, cervical cancer prevention, and looked at mainly the opportunity that the resources which were available from the PEPFAR and the Global Fund and also government were going to benefit more people if we integrated the cervical cancer prevention in the routine HIV. But also, besides that, the human resources was another thing that we did consider as well, and the ability to reduce the frequency of visits for women, that was desirable. And there was also looking at how do we uptake the sexual reproductive health services in a comprehensive way. And we had to also engage the task shifting. This has been reported also. The model which we have been using in Zambia for prevention of cervical cancer and general HPV as well. We started with where we placed nurses in different facilities, and they were linked to one central system. They would capture the images using cameras and send to the specialists, and again they would be able to go back and manage, and those that would not be managed, they would be able to be referred. So it was a comprehensive system, including the community outreach and also education and advocacy, which was very, very key. Over time, you saw that with the integration, when it started in 2006, within 2 years, we had almost 2/3 of our facilities were reached. And you can see the middle one is the number of HIV positives that we are reaching as we are moving with the integration. And when HPV testing and also HPV vaccination came in, the same model was utilized as well. This is a publication where we looked at the effectiveness of this integrated system, where you have the cervical cancer prevention program. So those lines which you see, the blue lines, the lighter lines, are showing the probability of the effectiveness, the number of deaths that are prevented, and the red, what you need to screen to prevent one cervical cancer death. And overall, with all those 27 permutations, you see that from between 238 to 96 deaths may have been prevented in screening 6,572, and also having appropriate interventions as well. So a range of one cervical cancer death was prevented for every 28 to 68 HIV-infected women screened, which we think is really highly impactful. Of course, there are challenges. The fragmented funding is also a challenge. Some donors may not be willing to invest into other programs, then staff fatigue as well, then lack of incentives, lack of staff and who are skilled, and that's why the linkages and also the referral system needs to be highly strengthened. So HPV DNA testing, we started in 2021, and the target was 350,000. We only reached 10%. I hope I'm not discouraging those that have not join us. I'm sure you have better outcomes. And we are hoping that by 2030 we'll be able to reach the 70%. And we are really encouraging that this is a good focus for HPV DNA testing, and also following the WHO recommendation. Countries we encouraged to develop the testing guidelines, then the validation of the various lab panels which they have, the platforms, and also the planning for procurement of the test kits, including the HPV testing as well. And for the vaccination, the HPV vaccination, from 2019, we're seeing that our coverage was about 75%, 2020, 85%. And during the COVID times, there was a drop in the vaccination coverage for both dose 1 and also dose 2 as well. And we've used a model where we use the campaign times when we have the Child Health Week, and also we have additional days at health facilities, in schools, and also in health centers. And the HIV infected girls, they are linked to a facility for them to receive the third dose as well. Barriers highlighted as well here. The issues of human resource, but also skilled resource. It's believed that if you cannot provide an intervention, then the prevention services may not be well accepted. So you need to have at least linkages to where you can have even a pathologist for them to review according to appropriate pathology, which is there. Then issues to do with the loss to follow-up, so data monitoring is very, very key as well, and need to address largely the patient barriers as well for you to have a well-integrated system. The community engagement, for us, it was something which we thought was a game changer with awareness at community level, education seminars. We had to use the traditional healers as well, the traditional leaders, and also where we would have the village-based screening and link this also to the vaccination as well. Now, the social media, television, and also these mass gatherings and the print media are important. And with COVID, we believe that it may have helped bring out the issues around vaccination, and I think we need to now pick back on that success for COVID vaccination so that we can integrate the HPV vaccination, not just in facility, in schools, but also in reproductive health programs as well. Countries that are moving into this area and also those that have started, you need to have a strengthened focus on the national cancer control strategic plans, and also have a lot of community engagement, civil society engagement, and to plan this with support on mentorship as well. But also importantly, the commodities, they need to be planned, and ministries have to pick up this as part of their routine services and promote the procurement of the medical supplies and also the consumables. So really, we believe that it's feasible to integrate the HPV prevention programs into the HIV prevention and also care models. And we believe that the community engagement is very key, and that we need to also look at how do we enhance the HPV vaccination, and for this to become part of the integral health service delivery aspect which we have to provide to our HIV infected women. We have shown as well that lives can be saved when you have sustained and also innovative approaches. Thank you so much.